Good day, everyone. Good day, Dr. Hill. Today, we will talk about the temporomandibular joint. Together with my group mates, we have made a folder that contains lecture notes, one based from Wolfell and one from Wheelers, and a video for all of us to better visualize and understand the temporomandibular joint. You can access it via the link that will be sent via our public chat. So, first, let us define the temporomandibular joint, or the TMJ for short. It is the joint between the condyloid process of the mandible and the mandibular fossa of the temporal bone of the skull. It is considered as the gangliomo-arthrodial joint, for it is a ganglimus, which is a hinging joint, and an arthrodial, or a sliding joint. This joint is responsible for the jaw movements. In fact, this is the most used joint in the body, for this moves every time we eat or we talk, or basically every time we move our mandible or lower jaw. And for us to better understand, let's take a look on its anatomy, or what composes the TMJ. First, we have the mandibular fossa. From the word fossa, we can tell that it is a depression. So it is an oval or oblong depression in the temporal bone. It is positioned just anterior the auditory canal. Here, we can see the auditory canal, and anterior to it is the mandibular fossa. To some extent, the shape of the mandibular fossa conforms to the posterior and superior surfaces of the condyloid process of the mandible. And anterior to mandibular fossa, we have the articular eminence, or which we also call the transverse bony ridge. Here we have a more zoomed in photo where we can see the articular eminence. So, what is an articular eminence? It is a part of the temporal bone on which the condylar process slides during mandibular movement. It is defined as the functional portion of the joint, for just like what we have mentioned, this is where the condylar process slides during mandibular movement. Posterior inferior surface of the articular eminence is lined with a thickened layer of a fibrous tissue to accommodate the sliding of the condylar process of the mandible.
The unique feature of the temporomandibular joint is the articular disc. It is a flexible, dense, collagenous tissue, and it is interposed between the condyle and the temporal bone. It serves as a cushion for the two bones, and the central area is relatively avascular, hyalinized, and devoid of nerves. It basically means that it is insensitive to pain. Anteriorly, it attaches to a lateral pterygoid muscle, a muscle of chewing, and posteriorly, it continues as a retrodiscal tissue that is fully supplied with blood vessels and nerves. In the next slide, the thicker anterior and posterior bands and the central zone is seen in this picture. It consists of a fibrous tissue to accommodate the shape of the condyle and the concavity of the mandibular fossa. It divides the articulating surfaces into an upper and lower compartments for smooth gliding function, and the upper head of the lateral pterygoid muscle stabilizes the relationship of the disc to the eminence. The mandible has two superior processes, the coronate process and the condyloid process. But in this picture, the condyloid process is the only labeled part. So, this is the part where the coronate process is located. Moving on, the condyloid process is a projection of the mandible, and it is convex on all bearings surfaces, although somewhat it is flattened posteriorly. And it is knob-like form is wider lateromedially than anterior-posteriorly. As you can see in this radiograph, it shows the temporomandibular joint in a open position in the left and a closed position in the right. You can notice that the articular disc is not seen in this radiograph because it is a collagenous tissue.
The last part of the TMJ anatomy is the joint capsule. It is a fibrous tube of tissue that encloses the joint. It is attached at the borders of the articulating surfaces of the mandibular fossa, so basically just around the mandibular fossa, and eminence of the temporal bone and to the neck of the mandible. The capsule consists of an internal synovial layer that surrounds the bones and their articulating surfaces. This thin membrane secretes a fluid, synovial fluid, which lubricates the joint. It also has an outer fibrous layer containing veins, nerves, and collagen fibers. The anterolateral side of the capsule may also be thickened to form a band called the temporomandibular ligament, or sometimes called the lateral ligament. This ligament prevents the excessive retraction or moving backward of the mandible, a situation that might lead to problems with the joint. Moving on, we also have accessory ligaments that include the stylomandibular and sphenomandibular ligaments. Though these ligaments have no direct relationship with mandibular articulation, unlike the temporomandibular ligament, they may function to stabilize the articular system during jaw movements. If we take a look at the picture on the right, the stylomandibular ligament connects the styloid process of the temporal bone to the posterior surface of the mandible near the angle. It is relaxed when the mouth is closed but becomes tense on extreme protrusion of the mandible. Meanwhile, the ligament here in yellow is the sphenomandibular ligament that connects the spine of the sphenoid bone with the medial surface of the mandible near the lingula adjacent to the mandibular foramen. It gives some support to the mandible and may help limit maximum opening of the jaw.
So when we say articular disc, jaw and open position, always take note that the bilaminar region of the disc fills in the mandibular fossa, while the intermediate zone of the disc is interposed between the anterior slope of the articular eminence and the condyle. The next one is centric occlusion or intercuspal position. In here, always take note that when we say intercuspal, that means the occlusal position of the mandible, in which the cusp of the teeth of both arches fully interpose themselves with the cusp of the teeth of the opposing arch. Centric occlusion refers to a position of maximal, bilateral, balanced contact between the cusp of the maxillary and mandibular arches. Centric relation is the most protruded and strained position of the mandibular condyle within the temporomandibular joint or TMJ. That is within the glenoid fossa. A number of problems can result in asymmetric premature dental contact upon closure with an unbalanced slide into occlusion that distracts the condyle and destroys its unstrained position. So the next one is rest position. Resting position is determined largely by neuromuscular activity and viscoelastic properties of the muscle. In here, take note that the resting position is not consistent, since sometimes the interocclusal space is about 1 to 3 millimeters at the incisors, but sometimes it becomes higher, up to 8 to 10 millimeters, but it is still considerable as normal. So the next one is the temporomandibular joint displacement. In here, it says here that it is an abnormal relationship between the articular disc, the mandibular condyle, and the mandibular fossa. In here, if the jaw opens too wide, it can get stuck in the wide open position, which is called an open lock. A patient can rarely get the jaw closed. Consulting a dentist is highly necessary. So, it is also the most frequent displacement of the disc is anterior to the mandibular condyle. However, in rare cases, it can be posteriorly. So the next one is the occlusal splint therapy. A TMJ disorder is usually caused by tooth grinding or clenching during sleep. That is why they are mostly worn at night. An occlusal splint is a removable appliance, most often designed to cover all of the occlusal and incisal surfaces of the teeth. Splint is made of thin, horseshoe-shaped layer of transparent plastic that fits over the upper teeth. It helps to reduce deflection of the mandible. And lastly, it is useful for temporary relief of pain, but they are not considered cures for TMJ disorders.